Discuss the suitability of ketamine as as a intravenous anesthetic agent. So PC, PK, PD, CUP, mechanism of action most important, and use pain. I've just put some stuff and bacteria, things that I'll probably forget that it's not like bacteria compared to propofol. Then PK, probably the most important is that it's an active metabolite, and the volume of distribution is quite high. PD basically just the fact that CV and SNS, myocardial depression, with an increased SNS in that balance. So ketamine, the uses is analgesia, induction, and maintenance. The way why you write cup D because it helps you remember that it's an analgesic. C is the class, so it's a phenylcyclidine PCP derivative. Mechanism of action non-competitive, NMDA antagonist at the PCP binding site of the NMDA, in the spinal cord and the CNS, and it reduces sodium and calcium influx, reduces action, potential propagation, causes inhibitory, and highly receptor affinity. Then you got PC, it's preservative benzoyl chloride, not suitable for neuraxial. It's water soluble, simple, cheap preparation, long shelf half life with reduced bacterial contamination. Mild pain on injection, but it's well tolerated. No significant environmental effects, and it's racemic, which S and R, where R is more bronchodilation, S is more the potent, and the cardiac depression. In terms of distribution, you have increased lipophilicity and low protein binding, which is 20%. Reduced KO, which is it's actually 3.5 minutes, so I don't think that's right. We'll just say reduced KO. Rapid onset, rapid equilibration time, but long T half life, which is 10 minutes. Slower offset, post bolus. High VD, which is 3 liters per kilo, which is great distribution. Intra-op loading facilitates post-op analgesia. It's a weak base. So remember ketamine, you have propofol, you have thiopentone, you have medaz. So this is a base and this is a base. And these two are acids. pKa weak base, 44% is unionized. Disadvantage compared to propofol and medaz, 100% and 90%. Then you have metabolism, so it's hepatic metabolized demethylation, 3YP3A4, high HER, active metabolite is norketamine. Plus renally excreted. The disadvantage, it's less predicted off-site, especially in renal failure because of the active metabolite, and metabolism is not affected unless it's severe hepatic failure due to high HER, which relies on HbF rather than intrinsic factors. Elimination is 17, relatively high advantage, context sensitive half-life plateaus around 30 minutes, after 3 hours infusion. The pharmacodynamics for CNS, you have dissociation, anesthesia, remember, thalamocortical and limbic system, and it has a dissociation effect. So TC and L. TLC or whatever you want to remember. TLC. Analgesic is reduced intra and post-op analgesia requirement. It reduces wind-up and long-term potentiation, reduces chronic pain. It's an NMDA antagonist of the spinal cord, but no anxiolysis. Increases nausea and vomiting, hallucinations and emergence. Increases SNS, increases CMRO2, increases CBF, increases ICP. Avoid in neurosurgery. EEGs, increasing BIS, difficult to monitor anesthesia. And then we have CVS, which is a direct myocardial depression, but indirect increase SNS, increase heart rate, inotropic cardiac output, and MAP. If already maximally increased SNS, catecholamine is depleted. Example, shock or increased inotropic can cause cardiovascular collapse because the depleted catecholamines. Also, an increased cardiac MRO2, and that was in the examiner report, can actually cause ischemia in ischemic heart disease. Respiratory is very important. A is hypersalivation, increases secretion, so disadvantage for maintaining airway. That's a disadvantage, obviously. Increase aspiration. But it maintains airway reflexes, it decreases aspiration, but difficult to put in LMA, and bronchodilation that are all good for asthma patients. All right.